Hello, back again. Welcome back, everyone, for our first of our afternoon sessions, which is mental health recovery in the pandemic. I'm not exactly sure of the topic title, but Patrick will tell us in a minute. I really want to thank Geelong Head to Health for sponsoring this session today. And remember to pop into the sponsors lounge. When you see at the top, there'll be a little link and you can have a look at the sponsors lounge, and when you go in there you get more points to possibly win the $200 prize at the end of the day. We had two speakers today, but unfortunately our second speaker, Steve Moylan, was woke up unwell, which seems to be the flavour of this year. A lot of people coming down with either COVID or influenza. So we're lucky to have Patrick Johnson. And Patrick Johnson is a psychiatrist, psychotherapist, and an educator. And he's the medical director of the Victorian Doctors Health Program, which is very relevant for today and for us at the moment. Patrick started in emergency medicine and then moved into general and then child psychiatry. And until recently, Patrick was also the clinical director of CAMS, which involved a lot of collaboration between different craft groups with paediatrician, GPs, psychologists, psychiatrists, a whole lot of different groups to work with. His particular focus is on consultation liaison psychiatry, and he works at the Royal Children's Hospital Pain Management Service, and he's very interested in teaching and teaches in quite a few different areas as Monash, and I saw in Dublin as well. So he's really got a lot of broad experience, and we welcome him to talk to us today. Thank you, Patrick.
And before you go, can you tell me how many people am I talking to?
Yeah, it's funny,
Roughly,
isn't it? It's funny sitting in this world where you don't have your audience. I think there's probably about 30 out there watching you.
Very good. Thanks, Anne. I know it's a strange thing, but to be so disembodied, it certainly isn't my style. My sort of style is meeting with specific doctors and students and talking with them, and I guess that's the whole aspect of the Victorian Doctors Health Program. It's very collegial, so we're very non-bureaucratic and non-administrative sort of focused. So the ideal, of course, would be for the audience to formulate their questions. They may have some, and we might be able to talk about some of those things at the end of our run through.
Certainly at the end, we always allow for questions, and we really encourage everyone to ask them, and I'll read them out to you at the end of the session.
Yeah. And I'll say, because I know that you represent sort of Western Victoria, I think, in the Primary Health Network. So I actually worked at Bendigo Health for 13 years. So I do know a little bit of regional country psychiatry and therefore GP. I went to Swan Hill for 13 years, and Echuca. So I've sort of got a sense of what it's like to be a medico in the country. The title was sort of sent to me, and I quite liked it because it didn't say mental health recovery. It was just recovery in the shadow of the pandemic. And I think it's interesting not to get so focused on these things as mental health. That can put some people off. It's, in some ways, it's recovering our well-being in the shadow of the pandemic. I'll just refer to my notes a little bit. So I think it's pretty clear that doctors' health has been an issue for decades, both in community practice and in hospitals and in training. The pandemic has, added an extra layer upon that, and that's without a doubt, with the GPs at the forefront, really, of the government initiatives and carrying a lot of costs and a lot of time burdens and a lot of expectations. And that trickling through to affect training for GPs, and then even medical students thinking of what path they're going to take, or junior residents. So it's had a significant impact. And I don't need to tell most of the audience, because it would have been nice to know what the mix of the audience was in terms of where they are in their training. But to some extent, and this is part of my talk, is GPs are pretty well versed in the question of health and well-being. And I guess what I want to do is capture the one or two of you out there today who mightn't have crossed that path to recognize that you need help. And so I'll tell you a bit more about the VDHP, and I'll keep an eye on the time. Okie dokie. Just going to move my slide over here so I can see it. There we go. So it was set up quite some time ago by, I think, a surgeon and an anaesthetist or a gastroenterologist. And at the time, it was really about physical care, that quite a lot of doctors had become unwell at different points in these colleagues' experience, not looking after their physical health or having addiction problems. So the focus has always been on making sure doctors who come to us have a GP, and recognising that GPs are at that point of contact into services, but also, particularly in the country, carry a great degree of that initial work and even ongoing work. Long when specialists aren't involved, the general practitioner sees that patient through and their family through. It's independent, and what that means is that we're not actually a state gazetted group, so we don't answer particularly to the state, and we don't answer to APRA. We get funding sources from both, and we have to argue that we're using our funding well, but they don't have any call upon our records or on the direction that we take the service. And that's how we maintain a degree of confidentiality, because we're not a clinical service proper. I don't prescribe. I might give some homespun advice, but we don't prescribe necessarily. We just talk with our colleague to help them find a way through the predicament they come along with. I've been in this role only for a year, and it's part-time, and I've already seen about 100 doctors for one initial appointment alone to think through their situation. And they've come with a whole range of questions. The mental health aspect seems to have grown, and there are other equivalent state services, but not as large as the VDHP, even though we're still quite bespoke. And the only one where there's a psychiatrist. In other states, it's, I think, mainly GPs who head the service. But the majority of people who come to see us will have some sort of stress, and that might be drifting into anxiety, or might be drifting or formally into sort of burnout, or it may have depressive elements. And sometimes that comes from direct workplace struggles. And sometimes there might be bureaucratic or administrative struggles that brings a doctor to our door. Substance abuse is fairly well represented, unfortunately. And that might be a doctor who comes along saying they've got a problem, versus someone who, well, they recognize they're not looking after their health by their drinking. The first thing we do is collegial discussion. I like that term better than assessment, in that it's about meeting with the doctor and thinking through, or the student, and thinking through their situation. And it can be short or long. And clearly I do cover, aspects of symptoms and self-harm and or thoughts along those lines. I mean, you have to, but it's very different from an assessment that I would do in a formal setting. And we can follow up someone for 2 to 3 to 4 to 6 months until they're well plugged into whatever follow-up we've arranged for them. And that linking to ongoing care is linking to GPs, psychologists and psychiatrists, sometimes pain specialists or sleep specialists or other avenues of care, even financial support services for doctors who, for whatever reason, aren't able to work. And that's maybe about 10% of the doctors we see are suspended. And so, they need to pay their rent or their mortgage, etc. And we might have to help them think through that. And obviously, maybe I'm recruiting as well. If any of you are interested in being a GP to a doctor or thinking about that field, then you can always let me know, because we have a number of GPs and specialists around Victoria who I can call directly. And I might say I've got a medical student down in Bairnsdale and this is what's happening. And so the GP down there will be able to help me think through the best way to help. They might be able to directly take that student on, but they'll know who's around. So that's a little appeal if any of you are interested. What I'm doing today is, I guess, something of the education, raising the awareness once again and advocating. We do a little bit of return to work. That might be more supporting letters indicating that a doctor or student has come to us, they've done the hard yards, etc., etc. And we have a really good support group, which I'll come to in a moment. So I better rush through my slides a bit. I think I've said most of this. And look, it doesn't have to be a big issue to come to us. It's not, it has to be a certain level of despair. I'll speak to a student about a failing exams they've failed, or about the question of getting mentoring, or even sometimes personal difficulties in life, and which may be spilling over onto their work, or they're afraid it will. It doesn't have to be always work focused directly. And this is probably the jewel in the crown. That's a support group that has been running for about 20 years. And in the end, it's almost a self-sufficient group, and there's about 15 doctors from around Victoria and a couple of students who partake once a week in a Zoom about their struggles with alcohol or other substances. A very supportive group, everywhere from those who see themselves as recovering or recovered versus those who just recognise that they're coming home from whatever workplace and they're drinking too much, and they're aware they can't quite get over the hurdle to put a stop to that. Yeah. Oh, okay. I see there we go. Sorry, folks. No, thanks for that pick up there. I'll have to move the other one so I can see my head. Not that I need to. There we go. So that's the support group. So this is the guts of the talk. I'm not an anti-vaxxer. This is really because some of the feedback that I get about why doctors are a bit jaded of well-being talks or self-care talks is we sort of all know there's no real vaccination against stress or against workplaces being extremely demanding. So I always want to make sure that nothing that I'm suggesting is that there are things that you don't want to put the blame back on the doctor if they become, or student if they become unwell or are struggling. That we recognise that none of us are immune from hardship in our work or personal life, and so we may, any of us at each time may be the one who is in need of some help. And I guess, partly my message is for the doctor or student who out there listening today who might be suffering or struggling or sad, not to retreat from coming forward, because you're not alone, really. In this little slide, in this one, I'm sort of indicating that well-being or recovery takes time, and one has to find something, a path, whether it's we all know the things we talk about. It might be a hobby, it might be relaxation, it might be music, it might be exercise. We hear this list of things to do, but any of these things take time, and they take time to actually become part of our life, and not sort of like in this slide, something that we sort of apply to ourselves. But it's recovery is about taking time to bring things into our life so that we can not just be distracted, but that we can nourish ourselves and our thoughts and our creativity. And that's a journey. I often think of, for example, someone who's burnt out, that it's like a rehab, actually, that it takes 3 months after a broken leg to see that the exercises you're doing they are leading to something. And then another 3 months before it starts to become something that you might even look forward to, because and then maybe even longer before you run again and forget that you were once so troubled by that particular pain. And burnout and depression and anxiety is a bit the same. I often think a rehab model is very helpful, because it makes people not despair that it's taking too long, but you can get an idea of the timeline in your mind. And again, just to reiterate that it's what you do really has to sort of get you going. It has to be the thing that interests you. It has to be often something that involves you with others, and something that takes you out of your normal headspace or your normal sort of routine, and something that, in a way, what floats your boat, the act, something that you might enjoy, that you can get back into doing. And that's a big part of recovery. For when people come to the VDHP, there may be the specifics of the institute they're struggling with, the specifics of the family story, or the PTSD they're suffering, or the events they went through. But around that, you have to foster an idea of getting back into life. So it's not just problem focused, and it just doesn't become grim. So you have to take their struggles seriously, but at the same time, the question of how to introduce things around the side that can make us partake in our life again. And it's not easily codified or researched or quantified, but I guess it's something that everyone here will know from their own experiences and own life. There's something of when you've retreated that you have to make those steps to sort of get back to enjoy the things that you once loved. And so I think that's a big part of recovery. Is people tell me, I don't enjoy that anymore. But if you did once enjoy it, you have to try and get that spark going again. There's not much point taking up something you've never been interested in. You've got to try to get back to something that once really was part of your life. And I think in some ways, to me, this is the best warning sign that someone's approaching burnout or in it. And that's when they drop the things they love and they're not doing them. So that whether it protects you from burnout is a good question, but it's certainly a sign that you're struggling. And if you're just going home and distracting yourself and no longer getting involved in the things that you want to be part of your life. And that might be your kids and your family as well, and how you want to interact with them. So I guess I've been implying through this that we hear the word self-care, and it's necessary, but I don't think self-care is sufficient in that we need healthy systems. And so that's another message to say very clearly, because we don't want the idea of self-care being like in immunisation, falling back onto our colleagues and all of us, where there's a lot of demands, and somehow we're supposed to cope. We do need to still advocate for healthy systems, whatever that might look like. A group of my colleagues have recently put out their research, and this is I've got the name of this book at the end of the slide. It's just been published. One of the authors, Natasha Smallwood, is on the VDHP board, so that's a disclosure there. And they had a research project with over 9,000 hospital workers responded, talking about their experience in the pandemic. And what the researchers found were they were overwhelmed by how many people actually wrote in. There were reams and reams of where, you've got that little bottom, you can make a comment if you wish. Well, this is the first time that everyone who sent that back virtually filled in, and some filled in pages. So it's sort of anecdotal, and it's divided into chapters, but if you're interested in some major research that came out of Victoria, that's well worth looking at, and it's probably going to be quite a landmark document that a lot of other research will emanate from. But when I read it, the major thing that comes through is the idea of collaboration and team and being recognised. These were the protective factors, and these were the factors that depressed people when the collaboration wasn't there, when the teamwork wasn't quite there, and when their contribution wasn't recognised. There were some interesting comments that in some areas teams functioned very strongly with very strong leadership, but the question of how everyone's involved in the decision making, and it's not just pushing the team to produce outcomes, but there's a recognition that everyone's sort of part of this new endeavour, because there was a lot of fantastic work done planning around EDs, planning around GP practices, planning around intensive care and how to respond to the pandemic, and some fantastic opportunity for teamwork. And some areas where that leadership was a bit more maybe puritanical or harder. So a very mixed experience. The other hard thing that comes through this is when there's isolation for the lonely medical student in particular, who just goes back to their flat, particularly those doing country rotations. That's something, unfortunately, we hear quite a little bit of that. That can be quite hard for some of the quieter, perhaps less outgoing medical students, and a lot of GPs too, even though they're in a practice with others. I hear that there's not always that time for interaction or thought or talking together. That's very much one can be somewhat on one's own. I certainly found that in my CAMS work, that I was doing more work via Zoom, less interaction with my colleagues, less corridor conversations, less direct interaction with the young people, and it wasn't satisfying, and I don't think it was as powerful, the interactions, in a therapeutic way. So the other thing that comes through this, I think, was that endless demand. We all doctors know about demands, and we all try to work out the need that we can do within that demand. But what happens when the demand just keeps coming, and we do what's needed, but that doesn't seem to reduce the pressure of demands? And I think that's something in the pandemic, the sense of an ongoing demand, where you shut the door at the end of the day, but the demand follows you home. So I like to add that self-care has to include relationships with others. And I think self-care alone is not a bad thing to starting point. It's necessary, but it's not sufficient. It's about being with our colleagues, and our colleagues who are friends as well. And there's a difference between colleagues who we work with, who we may like or admire, but something different again with a colleague who's a friend. And I've certainly found that through my career that I've got a number of colleagues who are also friends, and the ability to think and talk and reflect about the situations we're in, even though we work in different hospitals and parts of Victoria and Australia now, and even the world, there's a commonality of experience, and it's not that there's deep and meaningful discussions, there may be, but it's also just that understanding of how hard it can be. And I think that's a big part of a doctor's world, and a very thing one has to nurture for oneself. It doesn't just happen automatically. You have to think of it a little bit like something you've got to work at, keeping those connections. And when we finish seeing, when we start seeing a patient, we might start with about where does it hurt and how long, etc., etc. But the other key thing we always want to know is, and who do you live with? And so GPs know, and hopefully psychiatrists know, and hopefully all our other colleagues know, that who do you live with, and is a really key idea in terms of thinking about how to help someone, and also about how to help ourselves. So that's that message about relationships again, that self-care is fine. Prescribing to a person is maybe you may be very good with that. You may know a lot about the particular diagnosis, but the question of who do they live with is going to be key. Whether they've got first diagnosed psychosis, or whether they've got diabetes, whether they've got a broken leg, who do you live with structures how you think about their rehabilitation and their recovery, and how they can look after it and nourish themselves. And I think in this area it's the same. And so reflecting on our own lives, our own connections with families and friends, and whether we are making use of them in a constructive way, or whether we've drifted, and whether those home connections that we have and friends connections are sort of heading in the right direction we want, even if it's as busy as this particular household. So I've sort of rounded it off with some sort of truisms. And actually, I think this is my version of something that appears on the GP College's website. It's the doctor's, what's it called? It's the health. Oh, it's on the Royal College's website, and it's a contextual unit for doctors' health, and that's a really worthwhile unit worth reading. It's the Doctors' Health 16 contextual unit, and it's a lot more sort of focused than my talk today. It's a bit more academic in these are the sorts of things that doctors present with. These are the sorts of situations that can occur. My talk today is really just letting you know about the VDHP and trying, I guess, to appeal on a very personal, collegial level to make contact if you are struggling, and also for those who are interested, getting in contact to see how you could get involved in the broader help for our colleagues. So these are sort of the handy hints, and I've morphed it from the contextual unit, but I've used sort of everyday language, because we've got to keep these messages fresh. That's the hard thing. There's nothing here that no one in the room will have not heard of before. But how do we keep these ideas fresh and keep the discussion going, so ideas of self-care don't start to become a bit stale, and that we can leave today and think, is there something there that I have that's for me to think about and my health. Finish for the day. I have to use that one. I better finish off soon. I better do that. I do like the thing, you can't find time. that so I always say, I'll find the time, and you can never find the time for getting back to those things you enjoy. You can only put it aside and make it a regular thing. If you find yourself in that view, I'll find the time someday, you'll never find it. Colleagues, family, I think I've said most of these things. Invest in interests. People just don't have interests. You've got to invest in them. And when people come to me and they're really depressed, the real problem is not that they don't have things that they enjoy. The real problem is that they can't enjoy them anymore. And they feel very distanced and dislocated from the things they love. And that's sort of like a double whammy. And often you've got to keep those threads alive until you start to enjoy it again. I often think sharing ideas and experiences, in our training years, particularly in hospitals, and I did a little bit of GP work, but certainly in my psychiatry work, you're rushing from thing to thing, from patient to patient, and there's often not a lot of opportunity to think broadly about the different scenarios one saw and make cross references and theorize about that. So I think that's a big part of what's needed, is to take something away from the work and turn it into ideas about the therapeutic encounter, or how we deal with the difficult patient or the sad patient, or the family that come. How do we think about that in a general sense? And that certainly helps me in my career, not get overwhelmed by each particular patient that I see, where that could be hard if I don't have a broader sort of view on it. Lastly, therapeutic work shouldn't be discounted. That might be everything from having a mentor to supervision to therapy proper. And I've been involved, all of them, on both sides of the couch. So I speak from my own experience that I think supervision, for example, is a very important thing. I don't think we have enough of that built into the colleges. It's a little bit more common in those who've gone into psychotherapy training, and that's why I continued it and still continue it, both being a supervisor and receiving supervision. But I think that for me, if I could do one thing to help doctors' health, it would be to grow the idea of supervision as a lifelong encounter with another colleague, where we speak about our work. And it's not a supervision that the other one knows more than you, or sort of a snoopervision that we had back when we were training, but it's about the opportunity to talk and think about our experiences and make some sense of it. We've got a conference at the end of the year in December. Invite you all along. We're slowly putting up the website of what that will look like. And that's been organised by my colleagues in New South Wales and South Australia. And it's a great opportunity to meet other doctors from around Australia and their question of helping their colleagues. The South Australian one is mainly GP focused, and Roger Sexton, who runs that, has been in the field for a long time. So I'm really looking forward to that conference, and I think I'll get 5 minutes of glory at some point to speak, or 10 minutes. So I invite you along to that. The references, well, since I plagiarized the contextual unit, I thought I'd better put it there. The next slide is that book that I showed. The Australian Doctors Health Network, that's run by my peers, medical directors in other states. And lastly, the VDHP with our phone number and our email there. And I'd be very happy to hear from any of you at a later date, even today. I think that might bring me to the end of my slides.
Sally, I'm not on mute. Thank you so much, Patrick. So relevant right now, isn't it? I think quite a few people are struggling, and so I think we just have to admit. I think that's the problem, isn't it? We don't we just think we have to just soldier on. It's just
Yeah.
that cultural thing in our world.
The question for me, Anne, is yes, how to take it serious but not get grim.
Yeah.
And how not just to be sort of positive and rah, but have really good sort of working ideas about how to move forward, how to get some good conclusions, because and how to make the ideas fresh again.
Yeah, I loved just the things to take into consideration, and I also thought was really interesting what led to burnout, not having good teams and not valuing what people are doing in the teams. But actually, unfortunately, I think in general practice, it's a very ripe environment for that. Like, it's actually such a lot going on, and I think we don't spend enough time supporting our teams and valuing everyone in our teams. I think.
And I think that's true. And in one thing I think about burnout, and maybe it's just a bit homespun, but recluses don't get burnout. People who aren't committed to something don't get burnout. Burnout is something about those who are trying to work with others and putting their heart on their sleeve in a way. Burnout is about a lack of love. I think it's a type of it's and that's why we often think burnout is about losing love and passion for something. Couch potatoes don't get burnout. Burnout is something, and so the doctor is very prone, particularly the GP, with so many patients coming through wanting a little bit of a recognition from you, and you're sitting there feeling sad yourself or stressed. And the number of doctors that say, I often feel much worse than my patients when they come in, and I can't say it, but so yes, I think that's a good thing. Good point about the teamwork, Anne.
Yes. Now I've just Bianca's just left some great messages. Really grateful for the collegial friendships we've built through Project Echo. So that's a great way to connect with other of our practitioners. Really helped me personally.
Can you tell me a bit about that?
Well, I don't think Bianca can mute herself, but Echo is like there are different sort of cadence, but often they're weekly or monthly Zoom hookups with different interest areas. So there's a youth health Echo, there's a disability Echo, there's been a COVID Echo. So everyone can Zoom in and maybe present a patient and people can discuss it. So the ones that have engaged with it have found it really useful, I think.
Excuse my ignorance. Is that a initiative of your group itself, or is it a broader Victorian?
I think it's a broader Victoria. I've been involved in a pain and addictions one, and that had GPs from everywhere. But we've had local ones as well. I don't know if Bianca can put anything in the chat book.
Maybe that's Bianca can email me later on during the week, and we can see what if there's a part for us to be involved with that, or vice versa.
Yeah, sounds good. So Bianca has also put on the RSCGP contextual unit. She's put the link there. So I'm in the discussion, but if you've got questions, make sure you put them in the questions. Yes, we've got some questions here. Recognition of the terrible stress of health workers is a big issue. I suggested to an ED registrar and former nurse that they get an OA for their work, Order of Australia. And she said, no, just free frozen meals and have a mid-shift and take home, as sourcing today's dinner and tomorrow's workday lunch is a huge challenge for exhausted healthcare workers. So, yeah, just the day-to-day stuff is hard. So I don't know if you've got any comments about that.
Yes, I've just found out the discussion forum myself.
Yeah. There's a lot there. There's a lot in the discussion, which is fine. I can just read. Jane said collegiality. Yesterday's face-to-face opportunity was well appreciated after so many months of attempted engagement through Zoom. While that was necessary and grateful, I felt delighted to see people again. So yeah.
Yeah, and I
Um,
guess that goes back to that isolation, isn't it? That it's a real thing. At the beginning of the pandemic, I didn't mind that too much. I'm a
mm,
grey-haired old man, and I'd been driving up the Calder Highway to Bendigo and Swan Hill for years, and I thought, and I sort of liked the retreat for a period of time, and I was more worried for my kids, with their VC and all that sort of
mm,
stuff being mucked up.
mm,
But then it started to weigh me down as well, not seeing my friends as much. And I remember saying to my family, "Oh, I don't care about my friends. They know they'll come to my funeral. They know I'm here. They just, but it did wear me. I have to be honest to myself that it was actually quite sad not seeing them as much as I used to, and it was a loss, even though I sort of pretended it wasn't at first.
mm,
Definitely.
Yeah, it's there's a lot of convenience with doing things online, isn't there? But you know, as Jane said, just seeing people again.
Mm.
So Jane also says GP is essentially a solo occupation, so we have to work extra hard to keep up the connections and communication and enter and build up the team. And I agree with that completely, Jane. Very easy just to keep seeing patients in your room, and you have to schedule it, really, I think.
I've certainly heard that, particularly from some of the GPs in training who've moved from the hospital
Mm,
to GP work, and it's a different work, and obviously yourself and your colleagues there would be able to you would know that experience far better than me. My GP experience was fairly short; it was for about a year, um, and but it was a very different type of practice, and
mm, mm.
mm,
Actually, which I just want to, because one of the things you did say about you encourage supervision, and how would you see that working? Because I don't think many GPs get ongoing supervision at all. Like I'm
yeah,
interested to know.
I think there's two problems. One is there's not much of it. One is it's not embedded in the work we do, but the other thing is what would we mean by supervision?
Mhm,
And often supervision from we're taught in hospitals is about going over the case and looking at and thinking about what should or shouldn't have been done, rather than sort of a more broader hearing the narrative, hearing the story, um, and helping the person think and reflect on aspects of it. So I think that's the difficulty. It's the supervision I'm talking about is probably a little bit foreign to the hospital system, and therefore to GP field as well. But I might be wrong there. It's more that that open discussion with a colleague, rather than sort of that. That's why I said it's not supervision like Superman
mm,
or the old. It's really about well, when you start to talk about a case, you start to hear things.
mm,
You know, when you start to talk, you start to recognize patterns. You start to reflect on, well, why did I think that? What did I say? You might link it up with another patient you've seen or another situation, and you start to generate ideas. And I think that means you're not just left with the day-to-day grind, but you're growing your creativity and your experience and your maturity as a doctor about all those things you've seen.
mm,
We don't get a chance to talk about the many patients that we see who are really ill and struggling when we're in any of our settings. We see them and then we move on,
mm.
and I think there's something that seems odd about that.
Yeah, I mean, there is such a thing called the Valent groups. I don't know
Yeah,
if anyone
yeah,
in the audience is part of one of those, but it sounds like that's almost like a shared medical appointment, but on shared possibly patients that you might be struggling with. So doing it in a kind of group session.
yeah.
Um,
No, I think that Balint is probably the
mm,
closest sort of model. Yeah, definitely.
And Jill just says, I love to discuss the difficult and interesting patients with my colleagues, but time is difficult to find. And I completely agree. And then by the end of the day, as you said, leave on time. You want to be able to leave on time. Anne says, working in a multidisciplinary team as psychologist taught me about supervision.
Yeah, I think that's a great comment. I mean, I've been a bit spoilt working in CAMS and working at the children's, in that I've always worked with multidisciplinary teams, and where it's a sort of very flat structure.
But and then and might link back to you and the Victorian, that we have had peer groups. Ian said ongoing peer group support has been great for GPs and is currently being reviewed at PH, and at present they should certainly continue and be funded to the small level that they have been. So do you know about peer groups, Patrick?
Look, I'm just learning also what's out there. As I said, I've been here for in the space for a year, and I'm only starting to learn what is out there in a manifest way, and even the underground movements. There's some fantastic underground collegial peer groups that you only find out once you speak to people. So if Ian wants to send me an email and tell me a bit more as well, I'm learning into this space too, so that when I do speak to people like yourselves and we speak together, I'm not being Pollyannish. I know what's around, and I know what people are doing.
And there's quite a strong peer group network in our region, and they've been running for quite a while. But I think there's some danger that funding might get taken away. So,
and how many people are in that peer group? I mean, is it like 5 people who meet, or is it open? Or
there's probably a number. I wouldn't know how many, but there are probably 15 peer groups in our region, and they're all got about 5 to 10 people in those peer groups. And they all run in different ways. Some of them have been facilitated by a psychiatrist, and some just meet. They work all different ways, but I think they're kind of all grown organically.
Yes. It's good to know, because we get referred doctors from around Victoria, and we're often not aware of what could be available for GP or a student in different parts of Victoria, or even locally. It's only by hapstance I'll find out there's a good peer group that this particular doctor could make use of.
Yeah, well, Anne's just saying here she's been in her peer group for 25 years, and it's been 6 GPs and a psychiatrist facilitating.
That's fantastic. As I said, I'd love to hear more, even if it's just at an anecdotal level and just for my learning. Even for Anne, if you could say something about that for me sometime. It's fantastic.
So someone here's never heard of the peer groups, but heard through for colleagues. But I think they've been going for a while, but a lot of newer GPs in the region probably don't know about them. But we don't know what's going to happen. There's probably a risk but I think we really want to support them, because I think they are a great place for GPs to connect. I think. There's just one other comment here. Emily Jill Martin did a talk on avoiding burnt out for RSCGP, and she clinical supervision at my workplace, a clinical reflective practice model.
Oh, okay.
So I think, look, it's a work in progress. I think the risk of burnout at the moment is huge, and I think we have to be proactive about it, I think, in general practice.
Excuse me. Oh, very much so. And I guess you can be moving into that territory before you realize it.
Yes.
And that's one of the advantages of peer groups, isn't it? That we can tap each other on the shoulder if someone's sort of moved. We can't pull the wool over our own eyes in a way.
So Elizabeth, in the questions, we have a mental health social worker who facilitates clinical reflective practice in both group and single sessions, peer workforce support, and safe place to debrief. She's also written, we've been fortunate in practice to have. That was just her typo. She redid it. That's fabulous. She finds
But
that very useful. Yeah.
and are we talking about there are some particular practices that really get it right, and that there
Oh,
are
I'm
others?
sure. We're
You know,
so different.
we're talking about a mosaic of experience, aren't we? I think. But it's
Absolutely.
good to
Yeah.
hear from those who know when it works and why. And maybe
Mm.
it's not like a blood test. You can't always prove exactly what's going on, but you sort of know after a while. You give it credit. You can make a good argument. This has helped me. Yeah.
Well, I think we've come to the end of the session, so really thank you. It had a lot of discussion there, and it's a really important topic. And really thank you for taking the time to talk to us today, Patrick. And again, thanks.
I'm not sure if you can hear me. It's frozen, but thank you.